Hello, I'm Dr. Saroj Niraula. I'm an associate professor of medicine at the University of Manitoba and a medical oncologist at Cancer Care Manitoba with an interest in the treatment of breast cancer. I hope you all had a chance to recover from the recent ASCO 2021 annual meeting. Perhaps some of you did not yet have a chance to review the information that were presented, and it might have been overwhelming for some of you. The meeting materials were on the other side of the paywall, which may have deterred some of you. So in this video, I will discuss 100% of the abstracts related to breast cancer that were presented in various oral sessions. I hope you'll find this video useful. For disclosure, I do not have any real or potential conflicts of interests related to any of the abstracts, and I also have no association with any pharmaceutical companies, either financially or otherwise. So there were a total of 19 abstracts presented in oral sessions for breast cancer. 9 were in metastatic breast cancer, 9 in early stage breast cancer, and there was 1 that was presented in the plenary session, also related to early stage breast cancer. As I review the abstracts, I will offer you my assessment and opinion about the clinical trial design, results, interpretation, and implication in day-to-day clinical practice. The views that I present here will obviously be my own and do not represent that of my employer. So let me start with the study that really won the gold medal in this meeting in breast cancer, the so-called Olympia clinical trial that was presented in the plenary session. So I'll start by commenting that Olympia study has offered the potential to be a major breakthrough in adjuvant treatment of a rather rare but important subtype of breast cancer, the breast cancer that is associated with mutation in germline BRCA1 or 2. So this particular clinical trial was a multinational phase 3 placebo-controlled randomized control trial which tested the drug olaparib, which is a PARP inhibitor, versus placebo in adjuvant treatment of high-risk breast cancer after the patients have finished their initial perioperative curative intent therapies. This study stands on the fundamental understanding that inhibition of PARP family of enzymes exploit the principle of synthetic lethality to selectively kill tumor cells that have deficiency in homologous recombination repair, for which both BRCA1 and BRCA2 have very crucial roles. Patients needed to have relatively high biological or clinical risk. All patients had to be HER2 negative. If the patients were enrolled after neoadjuvant treatment, the triple negative disease must have had a non-PCR to be eligible, and hormone receptor positive disease must have had both non-PCR as well as CPS-EG score of more than 3. Similarly, in the adjuvant group, triple negative breast cancer must have had at least T2 disease or tumor more than 2 centimeters or node positive. And if it was hormone receptor positive disease, the patient should have had at least 4 pathologically confirmed axillary lymph nodes involved with cancer. So a relatively high risk population. Some of you who had chance to be part of this clinical trial will remember that it was not very easy to find eligible patients to enroll in this clinical trial because it required combination of both BRCA positivity as well as the aforementioned high risk features. The randomization between olaparib and placebo was 1:1, and the study medication was given for 1 year. The primary endpoint, as is the case with most adjuvant breast cancer clinical trials these days, it was invasive disease-free survival as per the STEEP definition. And the secondary endpoints, also quite common, distant disease-free survival, overall survival, BRCA1 or 2 related cancers, symptoms, health-related quality of life, and safety. Those were the secondary endpoints. The trial was designed to be a registration trial, so it had very robust statistical consideration with a power of 90% to detect invasive disease-free survival with hazard ratio of 0.7 with two-sided alpha of 5%, and adequate considerations were also given for pre-specified criteria to trigger interim analysis. And in fact, this particular report was based on IDMC review of the interim analysis in February of 2021 after just a median follow-up of 2.5 years in the intention to treat population and 3.5 years in the mature cohort. And as you would expect from a genetically associated breast cancer, the trial population was relatively young. Median age was about 40 to 43 years. And most characteristics were pretty well balanced between the two arms. So the results. The study indeed met its primary endpoint of invasive disease-free survival with hazard ratio of 0.58 and 99.5% confidence interval of 0.71 to 0.82 with absolute difference between the arms of 8.8% at 3 years. It was from around 77% invasive disease-free survival in the placebo group and about 86% in the olaparib group. And it's important to note that most of the events here were dominated by distant reoccurrence. Authors also presented data on distant disease-free survival, which was also significantly improved with olaparib, with absolute difference of 7.1% at 3 years. It was 80.4% in the placebo group and 87.5% in the experimental arm. Overall survival reports were also presented. The difference between the arm was at this time insignificant at 3 years. The absolute difference was 3.7% from 88.3% in the placebo arm to 92% in the olaparib group. The curves really seemed to separate really early in the clinical trial and continued to widen up to about 42 months that were shown in the slide. And it is very likely that the curves for OS will continue to separate, which is really impressive. So the subgroup analysis, it did not really offer any clear signal, but they were still likely to be unstable at this time, as the whole analysis was triggered by early interim analysis. So we need to wait for any signal from subgroup analysis. In terms of side effects, no surprises there. Nausea, fatigue, anemia were the most common side effects associated with the experimental agent, and they were rather lower grade rather than high grade. Treatment discontinuation due to toxicity was about 10% in the experimental arm and 4% in the placebo arm, so really a difference of 5%. Global health-related quality of life, which was a secondary endpoint, was also quite comparable between the arms. So those were the results in a nutshell. And I have about 9 comments to make on this clinical trial. First, it is almost certain, in my estimation, that olaparib will soon get the regulatory approval and will be funded. I think the testing for BRCA is going to be the biggest system change that this trial will bring about. Do we test all early stage breast cancer for this mutation? Do we only select those who are likely to be potentially eligible for this drug because the trial only included relatively high risk disease? Answers to these questions can have a real consequence to the system, particularly in publicly funded healthcare system like Canada, UK, and Western Europe. Second, what will be the implication of the efficacy of PARP inhibitor in metastatic setting? Because there are currently 2 PARP inhibitors, olaparib and talazoparib, that have data to support their use in metastatic setting. Will the efficacy in metastatic setting retain with prior exposure to PARP inhibitors? What will be the proportional benefit that the patients will derive when used in adjuvant versus metastatic setting. That is not entirely clear at this time, but this it's certainly a recurrent theme in breast cancer, as well as many other cancers in recent years. The counter argument to this would be that the efficacy of hormonal therapy, for example, continues to retain in metastatic setting despite exposure to in early stage breast cancer. The same can be said about the recently approved TDM1, which is available both in adjuvant and metastatic setting. Obviously, the timing of reoccurrence and the disease-free interval post-completion of olaparib would be an important factor for patient selection in that regard, in my opinion. Third, I wouldn't be surprised if eventually there happens to be an interaction between the previous use of platinum chemotherapy to the efficacy of olaparib based on the early appearance of forest plot in the subgroup analysis that were presented, especially because this is the exact group that may have mechanistic interaction with PARP inhibitors. But at this time, rushing to such conclusions right now would be rather hasty. So we will need to wait for longer term follow-up to further comment on this topic. Fourth, how about the eligibility? Will we stick to the trial's inclusion criteria? Will there be extrapolation to lower risk BRCA positive cancers? I can clearly see some creep happening in there in the real world, but whether that is appropriate or necessary is actually the important question. The way we practice and the way we don't collect such data, even time may not tell answer to that question ever. 5. About 80% of the patients were triple negative. So estrogen receptor positive disease was clearly underrepresented in the trial, which needs to be considered while interpreting the results. 6. Where do other adjuvant treatments that have recently shown efficacy in the same setting fit in? Specifically, CDK4/6 inhibitor like abemaciclib have recently shown efficacy in adjuvant setting. Capecitabine is already being used in the same setting. So if you ask me that question, I would say that olaparib is likely to be the treatment of choice for all BRCA1 or 2 positive cancers, and the other agents would be used if they fit in the criteria but are BRCA1 or 2 negative. 7. The 1-year duration of olaparib in this trial was really a choice of convenience rather than based on any scientific basis. And PARP inhibitors in other diseases have been chosen for a different duration. So is longer olaparib better? Is shorter equally effective? These questions in my mind really are unlikely to be assessed immediately. So we will need to stick to the 1-year schedule regardless. 8. What about neoadjuvant use of PARP inhibitors? In this video, I will later summarize another abstract where a single agent talazoparib used in neoadjuvant setting has resulted in more than 50% pathological or about 50% pathological complete response. So in BRCA positive individuals. So where does that fit in? 9. Most importantly, let's not forget that this is not a metastatic situation where everybody will require some form of treatment to control the disease, and the same drug is actually available in metastatic setting. We are talking about a curable situation here where many patients are cured even without olaparib, and all eligible patients are going to receive this drug. And so far in this trial, we do not know if olaparib will actually improve cure. I do recognize that invasive disease-free survival is a very important endpoint. Reoccurrence of breast cancer is the last news you want to deliver your patients. But the treatment with this drug does have real downsides. It does have toxicities, and it increases inconvenience to some degree to all of the patients that receive this drug. And vast majority of them are already cured without the drug. In fact, over 85% of people with early stage breast cancer including those with node-positive disease, are cured with existing treatment. Our aim, however, should be to achieve cure for 100% of these patients, and that can only be achieved if the new treatment in adjuvant setting can guarantee with a high degree of certainty that they improve the current cure rates, or at the bare minimum offer alternate benefits such as improvement in quality of life or cost. That has not yet happened with olaparib, but I'm hopeful it will someday. From the perspective of the system, there is a substantial cost to this treatment with 1 year of olaparib. If all BRCA positive early stage breast cancer receive olaparib, that cost will quickly be counted in millions of dollars before we realize it. This may well be justified if the drug actually improves the cure rate, and I sincerely hope it will. But until then, I don't think it is wise to dismiss the absence of overall survival and accept invasive disease-free survival as be-all and end-all for every new drug that we have. Breast cancer patients definitely deserve better than that. They deserve to live longer, deserve to live better, and that should happen without unnecessary compromise in the name of intermediate outcomes, really. And that can only happen if we keep our standard high and be objective in assessing the benefits of all these new drugs. So those are my thoughts about olaparib in adjuvant treatment of BRCA1 or 2 positive breast cancer that was presented in plenary session. So moving on. So metastatic breast cancer oral session consisted of 9 abstracts divided into group of 3 abstracts each based on common themes. The first section consisted of 3 different CDK4/6 inhibitors, one of which was a brand new addition to the class, dalbiciclib. So we now have a 4th agent to choose from when it comes to using CDK4/6 inhibitors. Isn't that great for our patients to have so many options? Well, it's a little bit more complicated than that, and I will talk about it. But first, let's delve right into what was actually presented. So the first presentation was by Dr. Cristofanelli, and it was an updated survival analysis from the PALOMA-3 trial. As you all recall, PALOMA-3 was one of the first pivotal clinical trials testing palbociclib in combination with fulvestrant in the treatment of ER-positive metastatic breast cancer, which had progressed previously on systemic therapy for metastatic disease, including chemotherapy. Importantly, the ribociclib and abemaciclib trials, which were done in similar setting, did not allow chemotherapy. So this trial was unique on that regard. The primary endpoint of this trial was progression-free survival, which was unequivocally significant right in the first report. And based on that, this combination had received FDA approval more than 5 years ago now. Overall survival was a secondary endpoint of this study, and the protocol specified final overall survival analysis had been reported after about 45 months of median follow-up. The primary analysis in intention to treat population had shown a difference of 7 months between the arm, but that was not statistically significant. It was about 28 months for the fulvestrant alone and 35 months for the combination. And this particular report in ASCO 2021 was an updated overall survival analysis after about 73 odd months of median follow-up. And indeed, this kind of reports are very valuable to breast cancer community, mainly because such reports give us further confidence on both ongoing efficacy and safety of the drug long term. But we shouldn't forget that this analysis by definition is really exploratory in nature. Therefore, although I would take the message from here very seriously, I wouldn't take the numbers that seriously. And hazard ratio, p-value, should not be taken too seriously in such kind of reports, in my opinion. Regardless, this report did show continued separation of the curves for median overall survival that pretty much mirrored what we had seen 2.5 years ago in the primary analysis, a difference of about 7 months in overall population. As usual, authors also presented many subgroup analyses to look for signals, and I'm calling it signal because it's exactly that, rather than anything definitive. But there were a couple of subgroups that where the signal was more noticeable. It appeared that patients with sensitivity to previous hormonal therapy did better, and those who were resistant did worse. And I don't think it's surprising in any manner, because hormonal therapy is really the backbone of this combination. Similarly, patients who were previously treated with chemotherapy did not have as good an overall survival as those who were chemotherapy naive. Now, what does that part actually tell you? That does not necessarily tell you that you should not treat women who previously had chemotherapy with this combination. I would assume that the reason that those patients received chemotherapy instead of hormonal therapy was because of associated poor disease characteristics, probably. As a matter of fact, there is some evidence suggesting that these patients who received chemotherapy had high mutation burden, about 20% of them having more than one mutation, likely resulting into less sensitivity to the CDK4/6 inhibitor combination. Then Dr. Cristofanelli went on to present the expression of 3 gene mutation analysis based on circulating tumor DNA analysis that was collected from over 300 patients in the baseline. The study team really should be applauded for getting such valuable sample in this trial. The authors focused mainly on 3 genes: the ESR, PI3 kinase, and TP53. In short, the message from this mutation analysis was that the mutation on all of these 3 genes were associated with poor prognosis in terms of overall survival, but the palbociclib combination on the other hand was predictive of benefit across all mutation subtypes. I think Dr. Cristofanelli mentioned in the presentation that the combination overcame such mutation, but I think that is inaccurate representation. The treatment did not overcome the mutation. It just maintained efficacy at much less potency than the intention to treat population, which is different from overcoming the mutation in my estimation. So that was the first presentation. Now, moving on to the second one. So it was also an updated overall survival analysis of ribociclib and fulvestrant in postmenopausal women with breast cancer in both first and second line settings. So about half of the patients in this trial by the name Mona Lisa 3 were treated in first line, half in second line. Like Paloma 3, the final overall survival analysis from this trial had already been presented after about 40 months of median follow-up previously, and this particular one report was update on that after 16 more months, about 56 months of median follow-up. This trial, as I mentioned before, did not allow previous chemotherapy use. So the results confirmed continued improvement in overall survival, with median overall survival of 53 months in the experimental arm versus 41 in control. So really gratifying to see that median overall survival is really approaching 5 years in this incurable disease with the use of these drugs, with almost 1 year of improvement with the addition of CDK4/6 inhibitor just in this trial. So that's very encouraging. Again, many subgroup analyses were shown, and results were true across all subgroups, such as those treated in first line, second line, sites and extent of metastasis among other subgroups. And like Paloma 3, patients in Mona Lisa 3 also had lesser chance of response to ribociclib in endocrine resistant subgroup, and other metrics such as time to chemotherapy, chemotherapy-free survival, and PFS2, which was also presented, which is a measure of outcome after progression on the experimental treatment. They all showed significant benefit with the addition of ribociclib to fulvestrant. One comment about this trial is that generally in clinical practice, at least where I practice in Canada, fulvestrant combinations are not typically used in first line setting. The go-to agent in first line treatment is a combination with an aromatase inhibitor, and fulvestrant is usually reserved for later line. And in some jurisdictions in Canada, fulvestrant is still not funded, so there are some practical implications of using ribociclib and fulvestrant combination in frontline setting. So most jurisdictions still use an AI in combination with a CDK4/6 inhibitor as the first choice. Another factor about using ribociclib is the need for EKG monitoring to assess QTc prolongation, which is not recommended for other CDK4/6 inhibitors. And I have heard from some colleagues that having to do EKG in itself has been a deterrent for some to use ribociclib. Now, I have seen Novartis making a point to justify the extra work to do the EKG by indicating potential higher benefit with ribociclib in certain subgroups. But in a nutshell, what we have seen is more of a class effect with these agents rather than anything drug specific. And I think there are more similarities between palbociclib and ribociclib than differences. So in the absence of clinical trial with head-to-head comparison between these agents, which do not exist, I wouldn't read too much into the subgroups. But it is entirely possible that one drug may be more suitable than the other, depending on various details. For me, despite the possible differences in target inhibition in CDK4 versus CDK6 and slight differences in numbers of hazard ratio, they're really, look like they're interchangeable, and they're equally fantastic addition to breast cancer drug armamentarium. So the third and the final presentation in this particular section was a Chinese trial, a fourth CDK4/6 inhibitor by the name dalpiciclib. It was assessed in the so-called DAWNA-1 trial. It's interesting how we don't run out of nice female names to name these breast cancer clinical trials. So DAWNA-1 was a 361 patient randomized controlled trial assessing combination of dalpiciclib and fulvestrant for metastatic ER positive breast cancer post progression on previous therapies. This trial actually involved or allowed up to one line of chemotherapy, just like Paloma 3. And the primary endpoint was investigator assessed progression-free survival, and there were a bunch of common secondary endpoints. This trial was also adequately powered to detect the difference that it set out to detect. The results: median progression-free survival was 16 months versus 7 months, favoring palbociclib, which was significant with a hazard ratio of 0.42. And like other CDK4/6 inhibitor trials, the benefit was seen across all common subgroups. Although I didn't see the endocrine resistant versus sensitive subgroup analysis in their presentation, I think. So overall, dalpiciclib did live up to the expectation, and there were adequate indications that this drug probably is quite comparable to previously approved CDK4/6 inhibitors like palbo and ribociclib so far, for both efficacy and toxicity, which are very comparable. So a few comments about this topic. The outcome that we have seen with these CDK4/6 inhibitors are undoubtedly excellent, but the real question remains. There has always been challenge in oncology in general to translate the findings from these high-profile clinical trials into clinical practice. We and others have previously shown that outcome in real life with these new drugs are worse than even the control arms used in these major clinical trials. So I think assessing real life outcome and finding ways to narrow the efficacy effectiveness gap has been the biggest challenge that we face in day-to-day clinical practice. Another point: more treatment options for the same indications are only useful if either the patient or the system benefit from having those options. Yes, there are some subtle differences among some of these CDK4/6 inhibitors, but in a high level, so far, all of these CDK4/6 inhibitors share more similarities than differences. Uh, a second drug in any class of antineoplastic drugs can be most justified if there is a advantage with regards to one of the four things. First, the efficacy itself. Second, toxicity. Third, more convenience to the patient, such as intravenous versus oral route of administration. Or fourth, the cost for the payers, be it patient, insurance company, or the public purse. I do not think there is any appreciable difference among any of these CDK4/6 inhibitors for us to consider one versus the other. Toxicities have conventionally been one of the criteria to choose these drugs, but really from among the three drugs that were presented in this session, I can't see too much difference in terms of toxicity either. Furthermore, we also do not know that a second or third CDK4/6 inhibitor has an efficacy after progressing on the first one. So why are we approving one Me Too drug after the other when there is no advantage of adding the new drug either to the patient or the system? There is not even competition in price. All of these drugs are equally expensive. These questions are the ones that we should have answered in yesteryears, in my opinion. If we continue to dip our head in the sand and pretend that these broader policy problems do not exist, it is sure to come back and bite us where it hurts the most. So let's be prepared for that. I want to make one more comment on this topic, which is that yes, we have seen that the outcomes from all of these CDK4/6 inhibitors are excellent, particularly in first line setting. What we really do not know is that can the efficacy be comparable if we overall efficacy if we delay CDK4/6 inhibitor to the second or third line. Yes, these drugs are reasonably well tolerated, and with proactive assessment, timely blood work, we can manage them well, but they still add more inconvenience to compared to the alternative, which is hormonal therapy alone, if outcomes are not compromised overall. So we need to know that. I think we will have a lot to gain in terms of convenience if we delay the combination for as long as possible, if we are confident enough that the overall efficacy is not compromised, and that needs to be assessed. There clearly will be patients in whom you would want to be aggressive upfront from the get-go and combine CDK4/6 inhibitor with a hormonal therapy in first line. But we all have patients in our practice that live for many years with single agent tamoxifen or letrozole. So we need to be able to identify them in advance, hopefully with further work on predictive biomarkers, and spare the appropriate selected group of patients the hassle of regular blood work and actually enormous cost to the system, which may not be necessary. Of course, this is a common theme that many other cancer drugs bring with them. Actually, there is a trial of first versus later line CDK4/6 inhibitor in Europe, and that trial hopefully gives some answer on that regard. So the second section of metastatic breast cancer session started with an abstract from Dr. Yuan from Sun Yat-sen University in China that looked at trastuzumab in combination with chemotherapy versus combination with endocrine therapy in first-line treatment of hormone receptor positive and HER2 positive breast cancer. Before we even start, as we all know, trastuzumab single agent has been outdated as the first-line treatment of metastatic HER2 positive breast cancer in most of the Western world, and for a very important reason. As we all know, the combination of taxane, pertuzumab, and trastuzumab have drastically improved overall survival of patients with HER2 positive metastatic breast cancer when treated in first-line setting. So unless there is any contraindication, we just routinely use this regimen in that setting in the Western world, which is a big caveat in generalizability of the results from this particular study. But nevertheless, this study does assess a scientific question which has very little to do with any commercial interest that I can see. And there's still a lot of places around the world where pertuzumab and trastuzumab combination is not accessible uh, for part or whole of the population. So these results will certainly be useful when trastuzumab is the only HER2 targeted therapy that you have in your arsenal, which is the case in actually majority of the world in my estimation. So 392 patients with HER2 positive, hormone receptor positive metastatic breast cancer in frontline were randomized to Herceptin plus plus chemotherapy versus Herceptin with endocrine therapy. The chemotherapy that were used were taxane, capecitabine, vinorelbine, so quite common and reasonable choices of chemotherapy there. The primary endpoint was progression-free survival. Secondary endpoint, overall survival, overall response rate, and safety. Pretty much typical of a phase 3 clinical trial in this setting. This particular trial was powered for non-inferiority with the non-inferiority hazard limit of 1.35. That was the upper limit, which I think which means that you are willing to accept up to 35% compromise in the outcome with endocrine therapy combination, which really is rather high in my estimation. So the analysis of primary endpoint showed that endocrine therapy arm was non-inferior with a hazard ratio of 0.88, 95% confidence interval 0.71 to 1.09, so well within the pre-specified criteria to declare absence of non-inferiority. So it's a positive trial indeed. Overall survival was also presented, and it was comparable between the arms with hazard ratio of 0.82, 95% confidence interval 0.65 to 1.04. Most of the subgroup analysis that were reported were also in coherence with the direction and magnitude of the summary estimate, except that for those who had disease-free interval of less than 2 years, in which case they derived more benefit from the use of chemotherapy combination rather than endocrine therapy combination. As expected, chemotherapy combination resulted in more side effects, which were all familiar side effects, and endocrine therapy obviously was, as expected, more well tolerated. So overall, this trial really confirms the hypothesis that we could use either chemotherapy combination or endocrine therapy combination for the treatment of HER2 positive metastatic breast cancer in frontline setting, with obvious advantages with endocrine therapy combination. So at least in short term, I think combination with endocrine therapy obviously will have potential quality of life advantages, although that aspect was not formally presented in this report. Now, the second abstract presented in the second session of the metastatic breast cancer was a clinical trial called Veronica study. Again, a nice female name. It was a randomized phase 2 clinical trial of second and third line use of venetoclax in combination with fulvestrant versus fulvestrant alone in ER positive, HER2 negative metastatic breast cancer. So venetoclax is a drug that we are used to hearing in the hematology world rather than in breast cancer. It is actually indicated in CLL and in small lymphocytic leukemia in later line post progression. So BCL2, which is what this drug targets, as you know, is a pro-survival protein, and in fact it's quite overexpressed in majority of both primary as well as relapsed breast cancer. So it was a natural experiment to occur, and there was a reasonable promise with this drug based on previous reports, which is why this trial was conducted. A very straightforward design, a small 103 patient randomized controlled trial in, as I said, ER positive, HER2 negative, either locally advanced or metastatic breast cancer, will randomize to fulvestrant with or without venetoclax. with the primary endpoint of clinical benefit rate, which was a composite endpoint of CR, overall response, stable disease for more than 24 weeks. And the secondary endpoints were progression-free survival, overall response rate, and duration of response, as well as some safety endpoints. Really not unusual choice of endpoints for this type of phase 2 clinical trial. The trial included patients that previously received all sorts of treatments, including endocrine therapy, chemotherapy, as well as combination of CDK4/6 inhibitor and endocrine therapy for metastatic disease. Overall, the result was that it was negative. The addition of venetoclax did not add to the efficacy to patients in addition to fulvestrant. The clinical benefit rate, which was the primary endpoint, was 12 versus 14%, 12% being on the experimental arm and 14 for fulvestrant. So slightly less response in the experimental arm. Progression-free survival, which was the secondary endpoint, there were in both arms it was about 2.7 months. 2.7 months for the venetoclax and 2 months for fulvestrant arm. Which was insignificant, which had an insignificant hazard ratio. Overall survival was not mature, but it would be unrealistic to expect that there would be a benefit seen in overall survival. In fact, there was indication of possible inferior survival outcome with the experimental agent, which is why death in the safety evaluable population was also presented. It appeared that almost all deaths were due to progressive disease rather than direct side effects from the drug. But there were more common or more frequent adverse events overall in the experimental arm, with grade 3 and 4 adverse events in up to 26% of the patients in the venetoclax arm versus about 12% in the fulvestrant. The presenter tried to make a point of possible trend of benefit in PI3 kinase wild type subgroup based on a 50-odd patient subgroup analysis. But I wouldn't take that comment too seriously at this time unless the sponsors really show data from a clinical trial which tests this drug just in the PI3 kinase wild type population, which I am not too positive that they will do. Also, the authors made a comment at last that effectiveness of BCL2 inhibitor in treatment naive or endocrine sensitive population is unclear, which really I think was unnecessary comment to make, because you could say that really for any other indication that the drug was not tested in, say in adjuvant setting, for example, or HER2 positive breast cancer and whatnot. So there are those comments we get to hear for a failed drug, really, quite often in oncology. So the last presentation in the second section of this session was a very special one. And this was a presentation by a patient advocate rather than an oncologist. It's very encouraging to note that ASCO recognizes the need to hear patient advocate's voice in an oral session, and I would really like to take a moment to applaud the selection committee for this. So the topic of this presentation was treatment-related side effects and views about doses assessment to sustain quality of life. Result of advocate-led survey of patients with metastatic breast cancer. So the concept here is that in metastatic breast cancer, dose is selected based on common phase 1 data that rely on maximum tolerated dose, which also likely maximizes the toxicity. And in real life, we all need to play around with the dose very often, all the time in clinical practice, and there is a lot of between patient variability. So it's a very relevant research. The investigators set out to explore the prevalence and severity of side effects, physician and patient communication, effect of dose on the reduction of quality of life, as well as patients' willingness to discuss alternate dosing opportunities. The goal here was to understand tolerability from the patient's perspective and willingness to discuss individualized dosing options. So those were the things that were investigated. So how was the study conducted? So 27 questions were created by patient advocates after first round of a pilot in 32 patients, and then the questionnaires were sent out using by online media. Yeah, basically, it involved only US based patients, and the patients obviously were anonymous. Authors used social media, online support group, email list, breast cancer organization, newsletters, things like that for wide dissemination. And there were quite uh, encouraging response. About 1,200 respondents participated, and so quite a large survey. Mostly they were Caucasians with age and demographics not too far away from typical US based metastatic breast cancer patients, and they pretty much replicated metastatic breast cancer patient in general practice, both in biological subtypes, lines of therapy, and most other variables. Mostly the patients were on targeted therapy. So that was the most common group, followed by endocrine therapy, but patients received all sorts of treatment like chemotherapy, antibody drug conjugate, with pretty comparable frequency to what you would expect for treatment of metastatic breast cancer in Western world, really. Without going into details of what exact questionnaires were there, what the study showed was that, as expected, patients in real life do suffer significant side effects from their treatments, which almost inevitably affects their quality of life. In this study, over 86% patients reported having had at least one bad side effect. 20% of them had to visit the emergency room or hospital because of the adverse events, and almost half of the patients that participated said they missed at least one dose because of an adverse event to the drug. Most patients did express their concern about side effect to their doctors, and majority of them received some intervention, including dose reduction, dose interventions, and things like that. Most patients did not believe that a higher dose is always efficacious, and 92% of the patients expressed that they are willing to discuss alternate dosing options to their care provider based on their personal characteristics, which is excellent. So overall, a very important study that assesses the actual difficulties faced by our patients in real life. Such efforts are absolutely necessary to remind ourselves that beside new drug development, which certainly is one of the major ways to improve patient outcomes, there are also more practical ways to improve patients' experience during cancer treatment. Drugs are only effective if there is uptake by the patients, really. So addressing tolerability and personalizing the dose is really just as important as discovering a new effective drug. So the third or the last section in metastatic breast cancer session also had three abstracts, of course, and it involved one chemotherapy and two immunotherapy studies. So let's first get the chemotherapy out of the way. So we'll talk about immunotherapy later. So the chemotherapy trial was a UK-based multi-center randomized controlled trial of 3-weekly cabazitaxel versus weekly paclitaxel in first-line treatment of metastatic HER2-negative breast cancer. Now, cabazitaxel has previously been assessed in later line in breast cancer with some signal of efficacy. So this trial attempted to move the drug to earlier line, which is quite quite typical. And the trial was pretty straightforward. It was a small trial, 79 patients in each arm with primary endpoint of progression-free survival and the usual secondary endpoints of overall survival, clinical benefit rate, time to next chemotherapy, quality of life, things like that. So the efficacy results of the trial were disappointing. There was no signal of benefit in either the primary endpoint or any of the secondary endpoints. Um, Although there was a suggestion of improved quality of life with cabazitaxel, now in the absence of real efficacy benefits, I'm not sure cabazitaxel is going too far with just the quality of life improvement shown in a very small trial. So not a clinically very useful trial, but with as with any negative trials, there are always lessons to learn. So the other remaining trials in this session were about immunotherapy. Uh, the first of which was a biomarker-based analysis of the previously reported IMPASSN 130 clinical trial, which, as you know, is the first-line triple-negative breast cancer trial comparing nab-paclitaxel with or without atezolizumab, which is an anti-PD-L1 antibody. I want to make a couple of comments actually about the parent trial before we talk about what was presented in this abstract. So the primary endpoints of the original trial, IMPASSN 131, were both progression-free survival and overall survival, and there was an improvement, statistically significant improvement in progression-free survival, and this drug received FDA approval based on that. However, this drug is not advertised based on that. It's mostly advertised based on overall survival in the PD-L1 subgroup. The trial had hierarchical design, meaning that first you perform the analysis on primary endpoint in the intention to treat population, and if that is positive, you move on to the subgroup. The primary analysis in the intention to treat population for overall survival was negative. So the investigators were supposed to stop right there, and they shouldn't have performed further analysis. But despite that, the authors went on to perform subgroup analysis on overall survival and discovered that there is actually a 7-month improvement in overall survival in the PD-L1 positive subgroup, which was not an analysis that should have happened in the first place. And don't get me wrong, it's always great to find signals in a subgroup, but those signals need to be used to design an appropriate clinical trial and confirm the hypothesis, and not to use such signals to sell the drug really, and that was an illegitimate analysis to use for that purpose. The drug is widely marketed as having overall survival benefit in triple negative breast cancer, which is not true. And I do not see any acknowledgement of the type of analysis in such advertisement. I think that's a breach of trust really to the patient that participated in the clinical trial, and scientifically it's less sound than it could be. Now, don't shoot the messenger. I am a breast cancer doc and I would love to get my hand on anything that can help my patients, and I certainly wished experience with immunotherapy in breast cancer would have been much better than what we are seeing so far. But I think it's our responsibility to communicate the research findings with utmost integrity to begin with. That's how the progress begins. There was also a second trial, very similar to IMPASSN 131, by the name IMPASSN 130. So the second trial was IMPASSN 131, where the chemotherapy backbone was paclitaxel instead of nab-paclitaxel, and that study unfortunately was negative, even for the primary endpoint of progression-free survival. Atezolizumab, however, it's still widely available in many countries in the United States, but in Canada, where drugs are publicly funded, this drug I don't think is even under review so far as I'm aware. Anyway, let's get back to the abstract that was presented. Basically, this is a study that was a breakdown of CDK4, breakdown of IMPASSN 130 patient population into different subtypes based on multiple microenvironment, tumor microenvironment, to see if there is any subgroup that can potentially be more appropriate for atezolizumab. So the tumors were divided by PD-L1 expression in the immune cells, obviously by TIL, by the location of CD8 expression in the tumor or stroma, tumor mutation burden, some genomic analysis, RNA sequencing, and so on. So lots of butchering to find the signal, and it's actually quite great for a generation of hypotheses. But before we go for the result, I think it's important to review some definitions that will be useful in discussing this trial. First definition will be based on tumor subtype based on immunophenotype, and then second based on molecular subtype. The classification is that according to the location of CD8 expression, or according to immune phenotype, tumors were subdivided into inflamed tumors, excluded tumors, or desert tumors, which exactly mean what they sound like in their name. And the classification based on molecular subtype there were four subgroups: BLIA, or basal-like immune activated; BLIS, basal-like immune suppressed; LAR, luminal androgen receptor; and MES, mesenchymal. So I think there is four main takeaways from what the authors presented in this analysis. First, according to immune phenotype, there seemed to be potential benefit of atezolizumab in immune-inflamed and immune-excluded phenotype for progression-free survival, but only for immune-inflamed subtype for overall survival, but no benefit in immune-desert subtype. However, any benefit that was found in any of these subtypes were limited to patients who had PD-L1 expression in immune cells. Otherwise, the benefit was just not there. Second, according to molecular subtype, BLIA and BLIS subtypes derived benefit in terms of progression-free survival, but only BLIA subtype derived benefit in terms of overall survival. Once again, all these benefits were limited to patients that had PD-L1 immune cell positive tumors, regardless of these molecular subtypes. The other subtype, like LAR and MES, did not derive any benefit from atezolizumab. Third point is that regardless of how you butcher the population, PD-L1 expression in immune cells was a necessary condition. That's the takeaway for any of these subtypes to respond to the study drug. In other words, none of these new subtypes so in none of these subtypes there would be benefit if PD-L expression was not there in the immune cells. Also, it should be noted that although BLIA subtype did seem to benefit, BLIA is also the subtype that has most expression of PD-L1 in immune cells. I think it was about 70%, very high. So I'm not sure if the authors presented anything to clarify whether the molecular subtype or the PD-L1 expression itself was the factor resulting into better sensitivity to atezolizumab in all of these subtypes. And hopefully those answers will be answered eventually and in the publication. Fourth point I want to make about this presentation is that in terms of tumor microenvironment, a positive outcome in atezolizumab was associated with proliferation and DNA repair, and negative outcomes were associated with angiogenesis, apoptosis, and estrogen response, among others. Now, the final presentation in metastatic breast cancer session was a study from Shanghai, China, and it was one of its type. This was a single-arm study that assessed a triplet combination of a PD-L1 antibody called camarilizumab plus anti-VEGFR2 TKI called famitinib with good old nab-paclitaxel chemotherapy in first-line treatment of metastatic triple-negative breast cancer. And they selected a specific subtype of metastatic triple-negative breast cancer, the immunomodulatory molecular subtype, which was based on the group's previous work, which had defined molecular subtypes of triple-negative breast cancer into four main subtypes. And that the immune therapy and VEGF drugs, according to their previous work, had best chance of response to immunomodulatory subtype, which is why they went ahead with doing this trial. So the patients had to meet the conventional criteria of being treatment naive triple-negative breast cancer, but they should have also had expression of CD8 in more than more than 10% of the cells by immunohistochemistry. It was a 46 patients clinical trial, single arm, as I said, and all of those patients received the triple therapy, followed until progression as per the RECIST 1.1 criteria or until unacceptable toxicity. And the chemotherapy was given for at least 6 cycles. The primary endpoint, which is pretty common in this type of trials, it was overall response rate. The patients consisted of a large proportion of patients with very high burden of disease, with 50% having lung metastasis and close to 50% who had more than 3 sites of metastasis. So, but the results were really more than just impressive, and I've never seen that in triple negative breast cancer. There was 81% patients that met the criteria for overall response, of which 70% were partial response and 10% were complete response. So that's a very impressive finding. The median progression-free survival in this single arm study was 11.5 months. Some exploratory analysis were also performed, which showed that the response was potentially predicted by presence of somatic mutation in BRCA1, KAT6A, and PKD1. You would expect that the triple drug combination would have significant side effects, but the authors did not really provide much detail, as much as I would have expected them to present. The good old phrase of relatively well tolerated or no unacceptable adverse events were used often in that presentation, which really are not objective statement by any means. But the report did say that about 50% of the patients had grade 3 or 4 toxicities. Fatigue, anorexia, and neutropenia were common adverse events. In addition to the immune-related adverse events, and the median cycle of exposure for each drug was about 8 cycles. So the efficacy results are really, really impressive and unprecedented for sure in this setting. I still have my doubts about tolerability of this combination, and if it can really be translated into Western population. Based on what was presented, these data are really impressive and do deserve a formal assessment in a well-powered phase 3 clinical trial. So we'll look forward to that. So those were all of the abstracts in metastatic breast cancer session this year. Hope you found the summary useful. Now we'll move on to locoregional or adjuvant breast cancer abstracts. So, like in metastatic breast cancer session, there were also 9 abstracts presented in locoregional and adjuvant breast cancer session, which were divided into groups of 3 abstracts based on 3 different themes. I think I'll go over this session in reverse order, starting with the last 3 and then moving backwards. So, in section 3 of locoregional and adjuvant breast cancer session, 2 abstracts involved immunotherapy and 1 involved use of adjuvant platinum. The first of this is a positive trial from the German breast group of durvalumab in triple negative breast cancer that was in neoadjuvant setting and was in combination with the standard chemotherapy that we often use in treating triple negative breast cancer in neoadjuvant setting, which is in this trial particularly the chemotherapy was nab-paclitaxel followed by EC chemotherapy. The primary endpoint, as is the case with most neoadjuvant treatments, is pathological complete response, which has already been reported before. And this particular report was a report on secondary endpoints, specifically 3 endpoints: invasive disease-free survival, distant disease-free survival, and overall survival. So durvalumab, as you know, is a PD-L1 inhibitor. But one thing we have noticed in early stage breast cancer with immunotherapy is that there does not seem to be too much of an association between the PD-L1 expression and response, unlike what we have observed in metastatic breast cancer. So that's something to make note of. The previous report of this trial, which reported pathological complete response, the primary endpoint, had shown numerical difference difference, but not a huge difference. So with the experimental treatment, with the use of durvalumab in addition to chemotherapy, the pathological complete response rate was 53%, and with chemotherapy alone, it was 44%. So about 11% difference, which is really peanuts if you compare it to other neoadjuvant studies that we have seen in breast cancer, for example, in HER2-targeted therapy and others. So very small difference. Statistical consideration in this trial, however, in my opinion, were pretty mediocre. You know, previously the trial was designed for event-driven analysis, but later it was changed to time-driven analysis, and there was really no adjustment for multiple hypothesis testing. Even the initial event-driven analysis had a power of about 13% to detect a hazard ratio of 0.77. All I would say is that the results should only be given the amount of respect in any trial that the statistical model actually deserves. It's a small trial, 174 patients, and the authors showed many subgroup analyses, which I would not read into too much deeply. So these were the results. Median follow-up was 3.5 years. There was significant difference in favor of durvalumab per all invasive disease-free survival, distant disease-free survival, and overall survival for 3-year event rates. Invasive disease-free survival was 85% versus 77% in 3 years. Distant disease-free survival 91 versus 78%, and overall survival 95 versus 83%. These are definitely impressive results, as well as statistically significant as well. Authors also presented a few curves based on pathological complete response and treatment that the patients received, and it appeared that not only was pathological complete response associated with better outcomes, which has always happened in triple negative breast cancer for all new agents tested, really, almost. So this is not a new piece of information, but interestingly, based on the curves that were shown, what I got from it was that you were better off getting pathological complete response in the durvalumab arm rather than getting pathological complete response in non-durvalumab arm in terms of long-term outcome. Obviously, this is only hypothesis generating, but quite intriguing. So what do you take away from this trial? If this is true, this speaks to the fact that you should be looking at a longer time horizon with all these immune checkpoint inhibitors and not be bothered too much with the immediate response when it comes to these classes of agent. Nothing we see there is definitive, but the signal is definitely there, and it requires attention and further work. Obviously, it is not yet time to be overexcited about this agent, because the results have to be taken in the context of sample size, statistical consideration, such as no correction for multiple hypothesis testing, and things like that. And another caveat of this study is that this study tells you nothing about whether checkpoint inhibitors have any role in adjuvant setting, which is a very burning question, and it doesn't tell you if it is even necessary in triple negative breast cancer in adjuvant setting. So those are the questions that will need to be assessed. So a few questions there. The second presentation in this section was rather interesting and something that we have not seen recently in breast cancer. It was a result from the I-SPY 2 group of trials, as I want to call it. So what the authors presented here was combination of paclitaxel, pembrolizumab, and a new drug in breast cancer, the intratumoral injection of the drug called SD101 in neoadjuvant setting. As we know, I-SPY 2 has a common control arm of paclitaxel single agent. So that was the control arm. Brief background. SD101 has previously been studied in melanoma and head and neck cancer, but I haven't seen this in breast cancer before. This drug is really a synthetic oligonucleotide that binds and activates the so-called toll-like receptors 9, TLR9, in plasmacytoid dendritic cells, which then releases interferon alpha, matures into antigen-presenting cell, and really stimulates the T cell. So when you inject the drug into the tumor, this really is focusing on tumor-reactive T cells. About the pembrolizumab itself, from previous I-SPY 2 trial, and Pembro has been reported out of this I-SPY 2 trial that it tripled pathological complete response rate in triple negative breast cancer and high risk hormone receptor positive cancer, and even the even the neoadjuvant trial, Keynote 522 in triple negative breast cancer had also improved pathological complete response rate, which we know from before. This trial was based on potential synergistic effect of pembrolizumab and SD101, which was seen in diseases like melanoma. This trial involved triple negative breast cancer and high risk hormone receptor positive breast cancer, but all of them had to be, even the hormone receptor positive had to be HER2 negative. So SD101 was given intratumorally every 4 weeks for the first 4 weeks, and then every 3 weeks thereafter. The dose was either 2 milligrams or 4 milligrams based on the tumor size. For tumors more than 2 centimeters, 4 milligrams, less than 2 centimeters, 2 milligrams. And if there was response, and if a tumor which was greater than 2 centimeters shrank to less than 2 centimeters, the patients received the lower dose, 2 centimeters. The sample size was small, 75 patients in the experimental arm. The combination arm, so the results, combination arm did increase pathological complete response in this trial with the combination. However, it did not meet the criteria for the combination to graduate from I-SPY 2 into a phase 3 clinical trial, because the predictive probability of success in a 300 patient phase 3 trial, which is the threshold that is set for all drugs assessed in I-SPY 2, it was 70% in this trial, whereas the threshold is 85% in to graduate. So this is a negative study. Authors also showed analysis of response by residual tumor burden, or RCB. As we know from before, RCB 0 and 1 have better outcome compared to RCB 2 and 3. What the authors found was that the combination was able to shift the tumor from RCB 2 to 3 to from 2 to 3 to RBC 0 to 1 in hormone receptor positive group, but that was not possible in triple negative group. In terms of adverse events, the rate of immune-related adverse events were higher with the combination than that would be expected of pembrolizumab alone. Although it's an indirect comparison, the control arm was not pembrolizumab, it was paclitaxel. But in indirect, so the adrenal insufficiency, for example, was seen in 12% of the patients, and there was one hypophysitis with the combination. But other non-immune related side effects were pretty much expected, like neutropenia, skin reaction, among others. So no big surprise over there. Authors also showed that the outcomes based on MammaPrint risk. So they ran MammaPrint. They do run MammaPrint in I-SPY trial. And there was nothing significant really that came out of that analysis to take it any further. There was no real signal in any of the subgroups that were shown. So that's the end of the story. So what I want to say about this trial is that in the context of previous data with pembrolizumab in this setting, I would have compared the combination with pembro rather than paclitaxel. but that's not how they run I-SPY 2. The control arm definitely was a wrong choice for this particular trial. Even with indirect comparison, it looks like SD101 would not add to efficacy seen with pembro alone, but it would definitely, it is possible that it would increase immune-related toxicities. So this was really a no-go. So the final study in this section is a really important study. Uh, this was a phase 3 clinical trial of platinum versus capecitabine in patients with residual disease after a neoadjuvant treatment for triple negative breast cancer. It was called EA1131 study. Basically, so it was to see if platinum could or should replace capecitabine, which was previously evaluated, as you know, in the CREATE X trial. A slightly different patient population, but the same concept, to see if we can further improve outcomes in patients with residual disease after neoadjuvant treatment, which we know is a high-risk population and definitely an unmet need, which are currently treated with capecitabine. So what we know is that breast cancer with basal subtype have higher risk of reoccurrence than other triple negative breast cancer, and the basal subtypes may be more sensitive to platinum from what we know so far, which was exactly the rationale of this study. The patients needed to have at least 1 centimeter residual disease after taxane-based chemotherapy plus or minus anthracycline. The PAM50 was the assay used in differentiating basal versus non-basal subtype in this particular trial. Randomization was between platinum, so it could be carboplatin or cisplatin. If it was carboplatin, it had to be AU cis6 or cisplatin every 3 weeks for 4 cycles, or capecitabine for 6 cycles, which was slightly less than CREATE X. And also the dose of capecitabine was also slightly less than that with what was used in CREATE X, but a common dose that we use in North American population, it was 1000 milligrams per meter square BID. So that's I think the most frequent dose we use in Caucasians. So there was initially an observational arm at the initiation of the trial, but when the trial was being conducted, CREATE X was reported, and then the observational arm was replaced really by capecitabine. Primary endpoint: invasive disease-free survival. Secondary endpoints: overall survival, relapse-free survival, and others. Of the participants, 78% or 308 patients were basal subtypes. So really, it was testing platinum in a population of triple negative breast cancer which was highly dominated by basal subtype. So a very necessary trial, in my opinion. It is a hybrid design. So it was designed to test both non-inferiority with a non-inferiority margin of 1.15. So the trial would accept up to 15% compromise in outcome, in the primary outcome. And it was also designed for superiority with an alternative hypothesis of hazard ratio of 0.75. So a very well powered compared to the ones we discussed before in this session. There was also a pre-planned interim analysis for futility if the conditional power was less than 10% and lower boundary of two-sided 95% repeat confidence interval was more than 0.75. And unfortunately, that was actually met in interim analysis based on the conditional power of based on the conditional power of 6%, which is less than 10%, which is why the Data Safety Monitoring Committee recommended that the trial be stopped because it was unlikely to either show non-inferiority or superiority of platinum compared to capecitabine. So the trial stopped. The interim analysis that was presented showed that the 3-year invasive disease-free survival was rather low regardless of the arm. It was 42% for platinum arm, 49% for the capecitabine arm. So the outcomes were, quite poor, even compared to create X, for example, which is not supposed, it's a cross-trial comparison, but still, that's the only data we have, and it was poor. Most likely because of the dominance, or almost certainly because of the dominance of the basal subtype. Similarly, results on recurrence-free survival and overall survival was also about 60% for both arms, so disappointing results. Adverse events were as expected, more hematological toxicities in the platinum arm and more diarrhea, hand-foot syndrome in the capecitabine arm. Patient-reported outcomes analysis are pending at this time, but they are unlikely to be too much helpful when the efficacy outcome itself does not support the use of the drug, really. The trial has also quite a rich tissue bank for correlative work, so let's be hopeful that something comes out of it. And that's all we can say at this time. Practically, capecitabine clearly is going to remain the drug of choice in this situation at this time, is the takeaway from this trial. All right, so let's move on to the second section of the local regional or adjuvant session. So there were two analyses of the German ADAPT clinical trials. Both were more of exploratory analysis and updates updates to the previous reports, which do not really add to clinical practice immediately, but they are definitely useful as hypothesis generating reports. The third trial, the third abstract was of neoadjuvant talazoparib, the PARP inhibitor, which is slightly different from the other two. But all three trials in these sections involve some form of pharmacodynamic evaluation of drug response, which is what links the drugs together in this session. So let's start with the biomarker and survival analysis of ADAPT hormone receptor negative, HER2 positive breast cancer. This particular trial looked at de-escalation of neoadjuvant pertuzumab and trastuzumab with or without paclitaxel weekly in hormone receptor negative, HER2 positive early breast cancer. So the trial design, it is a relatively small trial, 134 patients who were randomized in neoadjuvant setting to either pertuzumab trastuzumab alone or pertuzumab trastuzumab with weekly paclitaxel for 12 weeks. One unusual thing I noticed about this trial was that the randomization was 5:2, which I have not seen before. Not sure why that was done. So after PCR, further adjuvant chemotherapy was optional. Most people who did not receive pathological complete response obviously went on to receive adjuvant chemotherapy, but it was optional in the PCR or the PCR group. There was also 3-week tumor biopsy to measure a Ki-67 decrease to less than 30%. As well as low cellularity in the tumor, which is defined as less than 500 invasive tumor cells. So what we know from this trial is that pathological complete response rate was actually 90% with the combination of pertuzumab, trastuzumab, and weekly paclitaxel versus 34% without paclitaxel, which was the primary endpoint and it was reported before. I think 90% pathological complete response is beyond impressive, but that has to be taken within the context that the trial only included ER negative patients, which generally tend to be highly HER2 enriched, so they're really HER2 driven cancers. So 90%, that's impressive. What's new in this trial, in this presentation? This analysis actually presented time to event data, really, including overall survival, which are all secondary endpoints of this trial, as well as some biomarker analysis. So the following were the results. Invasive disease-free survival was 98% with chemotherapy and 87% with the antibodies alone, which was non-significant in statistical terms. Distant disease-free survival, 98% with chemo, 92% without. Again, non-significant, but it was based on event numbers of 7 events. And overall survival, 98% with chemo, 94% without chemo. Again, insignificant, and only 6 events were, this analysis was based on 6 events, and only 1 event in the chemo arm. So really, I don't know what to make of this data and the numbers. Other results, authors also replicated the prognostic role of pathological complete response versus non-pathological complete response, which, as I mentioned earlier, yeah, we know for a long time that there does exist a difference in outcome in patients who receive pathological complete response versus those who do not receive pathological complete response. What we do not know, and is the million-dollar question, is in the trial level, so the delta in PCR that is necessary to obtain a meaningful long-term result. What delta should a treatment be able to bring about to result into better outcome? That is the question that we have never known so far. Anyway, so basically, although a non-chemo arm had inferior pathological complete response, 90% versus 34%, if you in fact achieved pathological complete response, regardless of which arm you were randomized to, you did better. So, replication of the knowledge that we have had for a long time. Biomarker results. A number of biomarker tests were performed in this trial, including genomic analysis using PAM50, RNA signature using BC360 panel, and tumor sensitivity measured by change in Ki67 in 3 weeks. Not surprisingly, there was a predictive role of these biomarkers to test for pathological complete response rate as well as for DCR. But I wouldn't really look at this data too deeply into the exact numbers because of the sample size and very small event rates that drove the results, which are events are really in single digits. So we need to be cautious about overinterpreting this data. In summary, this is a very useful trial, but I could not find overly novel information coming out of this analysis. There were no big surprises, and both the time to event and biomarker analysis were limited by the number of events, as I said. So I think the trial results indicate that we may be able to get away without chemotherapy in strongly HER2-driven cancer. So that's something that is possible, most likely. And this trial also does point to a useful clinical question, which is, can we avoid chemotherapy in this group of patients if they actually achieve pathological complete response rate? But it doesn't answer that. And in fact, we are awaiting results from two major clinical trials which are looking exactly at this question in HER2 positive setting, by the name of COMPASS, COMPASS, and D-Crescendo clinical trial. So COMPASS is looking to see if adjuvant chemotherapy can be avoided after pathological complete response in neoadjuvant setting with pertuzumab, trastuzumab, and taxane, which includes both ER positive and ER negative. And D-Crescendo, it's exactly similar trial, but looking at HER2 positive, ER negative, and node negative tumors, so a lower risk. So the second presentation in this section was about prognostic role of oncotype DX recurrence score, endocrine response, and pathological factors in high-risk luminal early breast cancer from the ADAPT HER2 positive, hormone receptor positive, HER2 negative trial. This was actually analysis of two separate trials, the chemotherapy trial as well as endocrine therapy trial. It makes this analysis a little bit complicated, and I can't see how we can easily interpret the results for the given patient in front of us. So in brief, prior knowledge from this particular trial is that reoccurrence score plus Ki67 response can identify women with favorable outcome to endocrine therapy alone in N0 and N1 early breast cancer, irrespective of age and menopausal status. So that's what we know from previous results of this trial. What we do not know is in women with high risk disease that are treated with both chemotherapy and endocrine therapy, we do not know the independent prognostic role of either reoccurrence score or Ki67. So this study exactly looked at that in high-risk population based on conventional prognostic criteria such as more than T2 tumor, more than 2 centimeter tumor, grade 3 or Ki67 index of more than 15%, and less than 35 years of age, or clinically node positive. So these were the high risk factors that were chosen. I will not talk about detail about the trial design, which uh, was actually designed to address different question, which was already presented. But in summary, what the authors reported is that in this high risk population, tumor size, nodal status, change in Ki-67, they do have prognostic impact. One important point that the authors presented, and that is worth mentioning here, was the ability to possibly identify premenopausal women with intermediate recurrence score who may be spared chemotherapy. So that's something that is great to have, and I think that needs further validation. Because it will be an important addition to what we know from the RxPonder trial in a limited node positive disease in premenopausal population. So I don't think this study is going to change the way we treat these higher risk patients immediately, but it's great to have these exploratory analysis, and this should help design future definitive trials to look at this important question. So that was about that. And the third trial in this section of adjuvant or early stage breast cancer section was neoadjuvant talazoparib in germline BRCA 1 and 2 breast cancer, presented by Dr. Litton. This was a single-arm study where germline BRCA positive breast cancer that were HER2 negative and had a tumor more than 1.5 centimeters were treated with 12 weeks of talazoparib and just talazoparib, no cytotoxic chemotherapy, followed by surgery, where pathological complete response rate was assessed by central review. The initial plan was also to follow patients for survival every 12 weeks for 3 years, but that was quote unquote, there was a strategic change in the development of the drug in neoadjuvant setting. So the study was closed after the safety data of talazoparib were collected. I think the safety data were collected up until about 4 weeks post completion of talazoparib, and then that was the end of it. No further follow-up was done. So there was that, and we do not know any further follow-up because of that. So the sample size was 61, and 100% of the patients were triple negative breast cancer. Most were younger patients, as you would expect in BRCA positive population. So pathological complete response was very impressive. It was 45% just with single agent PARP inhibitor and without cytotoxic. So that has never been reported before, and it really opens up an avenue to de-escalate treatment in these BRCA positive patients. So very important piece of information over there. Most frequent treatment related adverse events was grade 3 anemia. Others were quite expected, like fatigue, nausea, which are common, but mostly grade 1 and 2. There were no treatment related deaths. 33% patients had dose interruption and 39 had dose reduction. So this was really the first study of its type. The study was terminated earlier, as I said, and long-term results could not be collected. But if you think about it, I'm not sure what the long-term results would have added to it, because most of these patients, I would assume, up until now, would go on to receive adjuvant chemotherapy, which would certainly confound the results. So despite early termination, I would say that this trial was absolutely able to cut the mustard, as they say, and it will definitely help design future trials. So moving on to the first or final section of early stage breast cancer oral session. So the 3 abstracts presented here were about using genomic tests to predict a benefit of adjuvant endocrine therapy using archival tissue from prospectively conducted randomized controlled trials. So first among those was titled Outcome of Patients with an Ultra Low Risk 70 Gene Signature in the MIND-ACT trial. So quick recap of MIND-ACT. So as you all recall, MIND-ACT is a phase 3 randomized controlled trial performed in hormone receptor positive early stage breast cancer that used MammaPrint, which is a 70 gene signature to categorize patients into a high genomic risk and low genomic risk category. The patients were also categorized into low and high clinical risk using modified adjuvant online system. Now, the patients that were low risk for both clinical and genomic evaluation received endocrine therapy alone. Patients who were high risk for both genomic and clinical received chemotherapy alone. And whenever there was discordance in the risk category between clinical and genomic risk, they were randomized to either endocrine alone or endocrine plus chemotherapy. Well, there have been multiple exploratory analyses of this trial, but the primary analysis of this trial had shown that the patient with clinical high risk but genomic low risk had excellent distant metastatic free survival with endocrine therapy alone, with distant metastatic free survival at 5 years of 94% with endocrine therapy alone and 95.9% with chemotherapy and endocrine therapy. So the main takeaway from MIND-ACT, the primary analysis, is that you could safely avoid chemotherapy in patients with clinical high but genomic low risk. So that was the primary takeaway. Now, this particular presentation by Dr. Cardozo from Netherlands Cancer Institute validates the pre-existing knowledge from two prior studies by Dr. Delahaye and by Dr. Asserman, published in JAMA Oncology in, I think, 2017. Regarding ultra low risk breast cancer. So what is known so far is that there exists a group of breast cancer patients almost exclusively ER positive and HER2 negative that fall under the category of ultra low genomic risk identified by the MammaPrint test. One of the two validation studies by Dr. Delahaye, which had relatively low number of ultra low risk patients, suggested that there was 100% breast cancer specific survival after 15 years of follow-up in this particular ultra low risk patients. And this was achieved despite the fact that 98% of the patients received no adjuvant systemic therapy. So that's something important. And the Asserman study had also shown an excellent outcome in the ultra low risk patients with a 20-year breast cancer specific survival of 97% just with tamoxifen and 94% even without any systemic therapy. So that's what we know previously about this ultra low risk group, and hence the name ultra low risk. So what this study set out to do was to look at the outcome of such ultra low risk patients using the MIND-ACT dataset. So what did they find? Few things. Number one, a sizable minority of MIND-ACT patients had low or ultra low genomic risk by MammaPrint, which was 1,000 patients, which is about 15% of the total 6,700 patients that were enrolled in this particular trial. Second, 8-year disease distant metastatic free survival was 97% for ultra low risk and 94.5% for low risk, low but not ultra low risk. And in Cox model that adjusted for clinical pathological characteristics, ultra low risk tumor had significantly better distant metastatic free survival compared to even the low risk patients with hazard ratio of 0.65, and it was significant. So ultra low risk patient did even better than low but not ultra low, based on the Cox model. When we talk about breast cancer specific survival, the ultra low risk patients had breast cancer specific survival of 99.6% at 8 years, whereas the low risk patients had breast cancer specific survival of 98%. at 8 years. And on the Cox model, that adjusted for clinical pathological characteristics. If the patient had ultra low risk, there was no effect of either chemotherapy or endocrine therapy use when we talk about breast cancer specific survival. So those were very important results. So what can we conclude from this study, and what does this add to the current knowledge on this topic? First, a sizable proportion of breast cancer patients have ultra low risk that are likely cured just with surgery alone and have excellent outcome even without any systemic adjuvant systemic therapy at all, which is a lifesaver for a lot of patients. However, so far we have not been able to precisely define those patients, and this study doesn't do that either. That's something for future. Second, the current study confirms that MammaPrint can identify ultra low risk patients, but whether all or some of these patients can be spared adjuvant systemic therapy is yet to be known. And just as a note, number of low and ultra low risk patients have increased over the years, and that there has been a direct association with screening mammography. Prior to initiation of routine screening mammography, say in 1980s, the studies have confirmed that overall in the population, 40% of the patients fell under a low and ultra low risk category, but that number has risen from 40% to 70% after routine population-based mammography was implemented. And even within the population of Mind Act trial, and they've done this analysis, if the patients were had screen detected breast cancer, there were 70% of them who had low or ultra low risk versus 50%, only 50% if the tumor were not screen detected or they were detected between screening mammography. We can talk about that more on I think I'll leave that for another day, because that's a big and controversial topic, because it involves the sensitive issue of mammographic screening. Anyway, without prospective randomized control trial to select ultra low risk patients that either need less or do not need adjuvant chemotherapy, the knowledge gained from this study remains mission incomplete, really. So the next two studies used NSABP B42 clinical trial tissue repository to assess predictive potential of two different genomic tests, MammaPrint and BCI score, to define patients that could benefit from the use of extended adjuvant endocrine therapy. The first one was by Dr. Terry Maimonas, which looked at BCI score, and the second one looked at MammaPrint. So brief recap of the NSABP B42 clinical trial. B42 was a study performed in postmenopausal hormone receptor positive breast cancer patients. Stage 1 to stage 3 were included, and the patients that were disease free at 5 years, after first 5 years of endocrine therapy, were then randomized into receive 5 more years of letrozole versus placebo. The results were presented in 2019 San Antonio meeting, which showed that 10 years of endocrine therapy did improve disease-free survival by 3.3% in absolute sense, and a breast cancer-free interval by 2.7%, and distant reoccurrence by 1.8%. And there was no effect on overall survival with extended hormonal therapy. So that was what the primary analysis of NSABP had shown. So the study by Terry Maimonas here evaluated BCI-HI index, which really measures estrogen signaling. As a way of background, the BCI index has two components: a molecular grade index of 5 proliferated related genes, and second part, which is H and I 2 gene ratio, which measures estrogen signaling, and that was the part that was used here. What we already know is that BCI has previously demonstrated a predictive role of endocrine benefit in 4 studies so far: in the Stockholm study, MA17 study, Trans-Atom study, and Ideal study, where a predictive role of endocrine therapy have been shown. So in this particular study, the primary objective was to determine if BCI-HI score is predictive of benefit from 5 years of extended letrozole therapy, and the secondary objective was to measure predictive performance of BCI-HI in independent subsets, which included nodal status, previous tamoxifen use, and HER2 status, as well as treatment and biomarker interaction by BCI as a continuous variable. So what did the authors find? The study was unable to meet its primary objective, meaning that BCI-HI score did not predict recurrence-free interval with extended hormonal therapy in the B52 trial population, both in BCI high and BCI low cohorts. The test for treatment by BCI-HI interaction was just insignificant. The study also did not meet the secondary endpoints, which is to say that extended hormonal therapy in the subgroup of patients based on nodal status, primary tamoxifen use, HER2 status, none of them were different by BCI high or low. The same was the case for all of the secondary endpoints, distant reoccurrence, disease-free survival, breast cancer-free interval. Nowhere was the interaction by BCI-HI status found. So that was the summary. As a recap of the parent B42 clinical trial, there was no difference in distant reoccurrence with extended therapy for the first 4 years of randomization, and difference only started to appear after the first 4, and the assumption of proportional hazard were not satisfied for BCI-HI cohort. Therefore, the authors also performed a time-dependent secondary analysis with the endpoint of distant reoccurrence. So in that particular analysis, after first 4 years, extended endocrine therapy benefit for distant reoccurrence was in fact significant for BCI-HI high cohort by 3.6%, but that was not found in BCI-HI low cohort. However, the extended hormonal therapy by BCI-HI interaction was again not statistically significant for any of the time intervals. Moving on to the subgroup analysis, the extended endocrine benefit was observed for distant reoccurrence after the first 4 years in node-positive BCI-HI high subgroup by 5.6%, those with prior tamoxifen use with BCI-HI high by 4.3%, and in HER2-negative subgroup with BCI-HI high it was 4.8%. The interaction was not significant for extended endocrine therapy by BCI-HI in any of the subgroups except for the HER2-negative cohort. These results are in contrast with previous findings that I mentioned before in MA17, Trans-Atom, and Ideal trial. The main difference between those studies and B42 is the contribution of contralateral breast cancer in recurrence-free interval. In B42, the main driver of event was contralateral breast cancer at 54% of the events, whereas in other trials it was low at 17%, 23%, in that range. So that was the main difference between B42 and the previous trials, which may have contributed to the results that we're seeing here. So the third or the last abstract presented the utility of MammaPrint assay for prediction of benefit from extended letrozole therapy in the same B42 clinical trial. The primary objective was to assess the predictive utility of MammaPrint with respect to benefit from extended endocrine therapy for distant reoccurrence, and the secondary objectives were to do the same thing for disease-free survival and breast cancer-free interval, as well as to determine the distribution of MammaPrint high, low, and ultra low in this trial population. So let me start by telling you the most important thing, which I don't think the authors explicitly mentioned, which is that MammaPrint does not give you prognostic information on the outcome of B42 patients in itself. So the outcome is not driven by MammaPrint results, which is to say that just because your MammaPrint is high or low doesn't tell you anything about your outcome, really. The authors found that the MammaPrint did have predictive value for extended endocrine therapy in the MammaPrint low group, but not in MammaPrint high group. The absolute benefit was 3.7% there. However, the test of interaction between MammaPrint high and low was not statistically significant. Similarly, MammaPrint had predictive value for the endpoints of disease-free survival, breast cancer free interval for MammaPrint low risk but not for high risk, and for these endpoints, the test of interaction by MammaPrint risk group were statistically significant, meaning that MammaPrint may offer predictive potential for extended endocrine therapy in MammaPrint low subgroup for both disease-free survival and breast cancer free interval. Absolute benefit of extended letrozole treatment in MammaPrint low were 3.7% for disease-free, 3.7% for distant reoccurrence, 7.8% for disease-free survival, and 7% for breast cancer-free interval. Within the category of a low MammaPrint risk, there was no significant benefit from extended endocrine therapy in MammaPrint ultra low, but the benefit was significant for MammaPrint low but not ultra low. The interaction test there was again negative between the two groups. The findings were pretty similar for disease-free survival as well as breast cancer-free interval, which is the benefit of extended endocrine therapy was significant for MammaPrint low, but not for MammaPrint ultra low. Conclusion: BCI-HI may be prognostic but not predictive, and MammaPrint may be predictive in MammaPrint low category, but not for, but it was not prognostic. So, those were all the 19 oral abstracts related to breast cancer presented in ASCO 2021 annual meeting. I hope you found my discussion useful. Until next time, ciao.